Thanks a lot, Ray. And I hope you guys don't mind. I'm bringing up my laptop so you don't miss out on any of the pearls of wisdom I have during this talk. Very excited to be here. Very excited to be giving the last lecture in the last session for 2018 at SAGES. So I work in Burundi, and my disclosure slide, I had to first make sure I understood what a disclosure meant, the act of making new and secret information known. So my only disclosure is that I have actually never done any laparoscopic surgery in Burundi, but I'm going to add the caveat of yet. So you may be getting a slightly different talk than the talks up to this point, but I still think it's an important talk. I would probably rename my talk as Bringing Laparoscopic Surgery to Burundi, Part 1, Infrastructure. And in a session talking about bringing laparoscopic surgery to resource-poor areas, I think it's really important to kind of really dig into the infrastructure piece. So I hope you find it informative. Maybe I'll be back in 2020 to give another lecture, another follow-up lecture. So why is it important? And why are you going to get a different type of talk? It's important, and I'm still here talking about laparoscopy because it fits into what we at Village HealthWorks see as our pillars of healthcare. You can see all these very common things: quality, excellence, being holistic, education, training. But really one of the most dramatic things that the clinicians that are on our staff that are Burundians that have been there their whole life, one of the things that's very important to them is to bring services to Burundi that don't exist. I don't know how much the audience knows about Burundi in general. If I were to ask the audience to point Burundi out on a map of the world that had no names, who would be able to do it? Okay, so not everybody. But even in Burundi, it's very important for the health practitioners that are there to establish services that don't exist. And a lot of services don't exist. Minimally invasive surgery basically doesn't exist. Things like oncologic care doesn't exist. That's one reason why I'm here, because I still think laparoscopic surgery is important. I think everyone on this stage would agree that despite your environment, it's important to have that high quality patient care that you would want for your family at the mountaintop. And it's important not just because of what Paul Severinsen has multiple times demonstrated, that poor people get more at a laparoscopic than rich people, but in doing so, it obligates us to tackle a lot of the really difficult challenges that are out there. If we in any way reduce our expectations, that a lot of times alleviates us from tackling some of the difficult challenges. And I think this is one way how we can, as not just surgeons, but laparoscopic surgeons, learn from the experience of HIV in the developing world. In the beginning, the paradigm was prevention. Trying to do antiretroviral therapy is ludicrous. It's too much money. It's too much cost. But the public health community doubled down on that, and it forced them to tackle a lot of the problems with respect to supply chain, infrastructure, costs. And over the years, it ended up being, as we have it now, the paradigm for treatment of HIV in the developing world. So some of the same lessons can be certainly applied to laparoscopy. So that's why I'm still talking about laparoscopy in Burundi. But the reason why the talk is going to be a little bit different than the previous talks is because Burundi is a different type of country. The context is very different. Burundi is one of the 3 poorest countries in the world. There are only 2 poorer countries, the Central African Republic and the DRC. It's about 11 million people in a country that's the size of Maryland, so it's the second most densely populated country in Africa. And 12% of the population is urban. So actually most of that population is rural. So that presents unique problems, particularly with respect to infrastructure. Infrastructure, meaning things basic like electricity, running water, sanitation, does not reach over 80% of the population. And this is the highest percentage of any country in the world. 80% live below the international poverty line. So the context is very different. This is an ultra poor country. And a lot of times, one of the things that suffers first and foremost in an ultra poor country is the health system. This is a great cartoon. You see the cartoon with the buildings on it? Have you guys seen this before? I love this cartoon. It's out of the Lancet Commission on Global Surgery. I use it all the time because it's a very nice representation of what a healthcare system should look like in the developing world. There should be clinics in the community. There should be comprehensive clinics. But the main driver for surgical care in the developing world is really this unit, the district level hospital. And in most countries, there ends up also being a tertiary care hospital that does training and education in the capital city. So that's, that's the way it should work in most poor countries. In a place like Burundi, in a lot of places, not just ultra poor countries, but in a lot of these countries that we all work in, there are deficits at each level. District level hospitals, they're charged with providing essential obstetrical and surgical care 24 hours a day, 7 days a week. In Burundi, these facilities really are unable to do that. Regional hospitals are supposed to provide specialized care, things like ENT, orthopedics, neonatology. In Burundi, that does not exist. And then the National Teaching Hospital, which is located in Bujumbura, that is tasked with providing specialized care. And it's also tasked with training people. In Burundi, unfortunately, there's very limited specialized care. As I said, there's no oncology, there's no dialysis, again, in a country of 11 million people. And there's also no graduate medical education system. The typical paradigm in a country like Burundi is that there are graduate programs out of the national university where you spend 3 or 4 years in the capital city, and perhaps you go on for finishing in Europe or another country. And that has been the paradigm for ever since independence in Burundi. But since 2014, there was a constitutional crisis. All those programs have been suspended. So the system in Burundi was already in bad shape, and really now it's in particularly bad shape. And to kind of further show you that is this man right here, Jason Frater, is the only surgeon working full-time out of the capital city. And there are only 13 surgeons in the entire country, 3 anesthesiologists, less than 300 physicians overall. So you can imagine what this means for millions and millions of people. Jason has been at what's called Kibuye Hope Hospital. It's a mission hospital in central Burundi. And in ultra-poor countries like Burundi, what ends up happening is that the national healthcare system, unfortunately, is not in a position to be a helpful partner. So what ends up being necessary is a lot of coordination between donor communities. And so a lot of the network of healthcare in the rural communities are actually served by facilities like mission hospitals, but also like ourselves. And ourselves is Village HealthWorks. Whatever you end up doing in global surgery, it's really important to understand the context, but also understand what your platform is. This is the organization I work for. It is a healthcare organization, however, it spans a lot of other domains as well. We have programs in education, agriculture, economic development, and cultural engagement as well. And we are located in rural southern Burundi. It's probably helpful for you guys to kind of see a map to get the lay of the land in the country. We are down here where it says Kigutu, and Bujumbura is capital city. These 3 green box cities are hospitals, have hospitals. They're supposed to be regional referral centers. Again, that are supposed to be able to do specialized care, but they really can't. All these blue hospitals contain district-level hospitals that are be able to provide surgery and emergency gynecologic care, but many of them do not do that consistently, and the quality is often quite poor. So there's a serious lack of care facing the communities in the southern part of the country, not to mention the country as a whole. And since 2006, this is Village HealthWorks campus. You can see it's developed quite a bit. And back to my fancy cartoon, to kind of represent where we are in our development stage, we run a full comprehensive clinic and inpatient hospital. However, we don't have any operating rooms. So our census is usually anywhere between 50 and 100 people. We take care of malnourishment, infectious disease, non-communicable diseases, do uncomplicated deliveries, have a mental health program, but we do not have surgical services. And so we're faced with the the decision of what's the next step for us. And if we look at the situation in the country, it forces us to be rather bold. And our vision is to build a hospital that is not only a district-level hospital that functions in this domain, but then also is able to provide services not available in Burundi. And this is where the laparoscopy piece comes in. And finally, to also help revive the national teaching program, much in the same way Paul Severinsen does in Haiti. How do you buttress these programs that are in place that are having problems themselves, finding cases and training young medical students? So we embarked a couple years ago on development program to build a hospital in Burundi. And when we started, it was pretty apparent that we kind of really had to back up. And we had to back up pretty far, because all these things that have eloquently been pointed out by a number of our panelists didn't exist in our community, whether it's clean water, sanitation, or energy. We had a lot of work to be done on infrastructure. And you have to understand what your demands are going to be, and you have to understand what your available resources are, and come up with a plan. So, water demands in a district-level hospital are vast. It's not just hand washing, environmental service, but you have laundry services, you have sterilization. And so what we had to do is go through a process of estimating how our water demands are going to increase with the building of a district-level hospital or larger hospital. And you see they increase anywhere from 2 to 4 times. And what we ended up having to do was invest in a second water tank. We had to establish a system that would allow us to prioritize water for the hospital. So we don't run in those situations where we have limited resources and some of it's being siphoned off to the community, when in acute situations it may be better off in our healthcare area. So developing networks are important, particularly when it comes to electricity. District-level hospitals, if you're going to have these types of services, really account for a lot of energy. As you can see here, our energy requirements now are 20 to 30 kilowatts a day. And in a typical district-level hospital, you're at least running between 150 to 200, with peaks that can be as high as 300 and 400. So we had to get really serious about coming up with our plan for infrastructure. And what we turned to pretty quickly was a solution that incorporated micro hydroelectric power. And this is kind of a design plan. And we got after it in 2014. We designed this micro hydroelectric system, and it was finished in 2016. And provides us with a sustainable source of energy. And the reason why this is super important for us is because in Burundi, only 6% of the population is connected to the grid. And even if you are connected to the grid, there are frequent outages, right? Adisa showed us in his, in his presentation from Nigeria. You don't want to have interruptions in your power supply. And so it's not about just getting sustainable power, but it's also being able to manage it in a way where you can alternate between sources, and you can also prioritize portions of the hospital. And in order to do that, you need, you really need something called a microgrid. And part of our design for this hospital is the implementation of a microgrid that'll, again, prioritize energy inputs and outputs to critical areas. Another big thing is, wastewater treatment. Currently in Burundi, there is no wastewater treatment. Do you guys know what our options are for wastewater treatment on campus? There's not a lot, like septic tanks, pit latrines, but that's the way this works in a lot of the rural settings. But we've taken the opportunity to implement a program that'll try and use a small, self-contained wastewater treatment plant. And so this is actually the wastewater treatment plant that was put in place in the Mirabelais Hospital in central Haiti, where Paul works. And it's a self-contained wastewater treatment plant that is essential for a facility of this size. So I would feel really bad if I didn't include this slide in this talk. I feel that any slide talk that touches on global surgery, this is really a crucial slide. And what it kind of represents is that if at the nexus of your intervention is a hospital, that necessitates you have to do all these other infrastructure pieces. And all these other infrastructure pieces are actually the key to lifting communities out of poverty. And this is a pretty, in Global Surgery Corners, this is a pretty famous article that was in the New York Times 4 or 5 years ago. It's written by John Mira, who did a lot of work with the Lancet Commission on Global Surgery. And it was wonderful to see this, and I love this article. But if I were to have one critique, I think it leans a little bit too heavily on the idea that we do surgery on people, they're all of a sudden going to be healthy, and they can be productive members of the economy. I think the real trick is that if we make surgery on intervention, we kind of trick the public health community to having to do all these infrastructure projects that actually have a long-term effect on lifting communities out of poverty. So I think that's something to keep in mind. I'm running out of time, so I'll kind of get to where are we now. This is the construction of the hospital. We're about 25% complete. The process of doing a construction project in a country like Burundi is maddening and is an entire presentation, if not an entire session altogether, so I won't really go into it. But we're on our way with construction with many headaches and obstacles, but we're getting there. We can now kind of start to turn to some of the infrastructure pieces that you guys may find a little bit more interesting, that are a little more clinical. And one of the biggest ones is medical gas. And one of the big questions you have to identify early on is what medical gases do we want to provide in our hospital? What would you guys prioritize? Oxygen. CO2, because we're going to do laparoscopy, right? But there's a number of other things that, you have to kind of understand what your paradigm is going to be. Are you going to have medical vacuum in the walls? Are you going to use portable suction? Do you need medical air and surgical air? Does everyone know what WAGD is? So go into your operating room and go look at the hoses coming out of the wall for anesthesia, and you will see something labeled WAGD, which is waste anesthesia gas disposal. And so it is a requirement in every operating room in the United States. But I've never seen an operating room in the developing world with WAGD. Would you say so, Adisa? So it's interesting. You got to kind of understand what you need to prioritize and what you don't need to prioritize. For us, it's pretty simple. We're going to use oxygen, and we're going to have portable medical vacuum. But the big question is how? So how do we get the oxygen here in the United States in our hospitals? You just like plug it into the wall, right? But where does it come before that? Usually comes something like this, right? Some big trucks, but this is unfortunately not an option in Burundi. The options, though, are actually pretty well known. This is a oxygen generator, that condenser that'll go directly into a hospital. This is another paradigm that's used a lot, which is an oxygen generator, concentrator, cylinder filler, and then you hook it up to manifolds that can go to different parts of the hospital. So obviously this is key. You can't have gaps here. You got to be able to have an airtight oxygen distribution system. But what about CO2? And this is a big question. And if we want to do a laparoscopy in Burundi, where are we going to get our CO2? And so what I turn to is the only surgeon in Burundi that is doing any laparoscopic surgery. There's one guy that does some laparoscopic surgery at a private hospital in the capital city, at a hospital called Kinundu. And he uses CO2. But in the United States, medical gases are regulated by the FDA, and they actually have paradigms to talk about the limits of contamination that are acceptable in your medical gases, including CO2. So, I had to ask, where is this guy getting where is he getting his CO2? And do you guys have any idea where he might be getting his CO2? Ray said Coca-Cola, and he's very close, but they're getting it from the brewery. Every country in Africa has got a brewery, and this is one of the main ways you can get industrial-grade CO2 for laparoscopy. I still have questions about whether or not that industrial-grade CO2 is safe. I keep asking around, and no one seems to have a question. No one seems to have an answer for that. So if anyone has any experience in this, I'd love to hear their 2 cents. I'm running way over, so I'm going to wrap up. But the challenges in the future are no less daunting than these infrastructure challenges, and a lot of them have been outlined here by other speakers, but it's really important to understand what your baseline equipment needs are and what are your strategies going to be to fill them. Are you going to use medical refurbishment supply organizations? Are you going to use vendors? Are you going to use donations or locals? And the main thing is you want to avoid situations like this where you're getting, big containers of stuff you just don't need. And that's really, really important because you're already resource constrained. You don't want to waste time in human resources dealing with equipment you don't need. With the baseline equipment, you also need to make sure training is included. And importantly, you need to make sure that the appropriate technology is used. And this is where there's a lot of opportunity. This is something called the universal anesthesia machine. I don't know if anyone has seen this or used this. Does anyone use this? This is an anesthesia machine that has been developed by a nonprofit medical device company here in the United States called Gradient, and it is an anesthesia machine that can work without electricity or oxygen. But the question is, how do we engage nonprofit medical device companies like the ones that have all the big booths downstairs, even though, sorry, they're not nonprofits. But how do we engage companies in trying to develop things for resource-poor settings? It's happening in anesthesia, it's happening in some other surgical fields, but it really hasn't happened in a big way, I would say, in laparoscopy. So you got to understand your baseline needs, you got to understand your consumables, and this is all really about getting the right supply chain team and procedures in place. And then finally, how are you going to manage your biomedical engineering needs? Paul had some great slides of their biomedical technicians trying to repair stuff. And the question is, what is your paradigm going to be? And more and more in poor countries, there are different solutions. This is an organization that's actually a Kenyan nonprofit that provides biomedical engineering services to hospitals throughout resource poor settings in Eastern Africa. So this is the type of thing you can actually hire them, and they make, you know, weekly visits, and they do the rounds, and they fix your stuff. But having a plan is really important. And then finally, you can't stress enough the fact that you have to build a team, and team across a wide variety of skill sets, whether it's developing your current staff, hiring new people, doing proctoring or telemedicine and mentorship, but it's key. You can't underplay training and education, but what we found is one of our even bigger challenges is actually employee retention. And this is really difficult when you're working in a poor country in a rural setting. Most of the skilled staff wants to be in the capital city. And so retention of the people you train is not just about salaries and benefits, but a lot of times it's about your family, whether or not they can go to schools, whether or not they can have employment opportunities. Another reason why at Village Health Works we try to extend our scope as much as possible. This is a preschool that we just built. Some of our staff is now sending their children there so they can live on campus. So this type of really broad view is important if you want your facility, if you're in a rural country, without a lot of options to be sustainable. You really got to think about the family outside of your healthcare professionals. So that's the end of my talk. I will conclude with a quote from Paul Farmer, who just reminds us involved in surgery that it's important to talk about infrastructure in training, particularly when you're talking about the poorest of the poor, because a lot of times that's what trips us up, is infrastructure. And hopefully someday I can return with a picture like this from Burundi. This is actually from Haiti. I don't know, Paul, if you remember this. You may even be in this picture doing the first laparoscopic surgery at the public hospital in Haiti. Thank you.